Um, okay, let's see. How do I want to start this? Hello, everyone. Welcome to today's discussion with Dr. Garfinkel, our esteemed guest. Welcome,
Hello.
Dr. Garfinkel.
Hello. Thanks for having me, Gavin.
Yeah. Today we're just going to cover precepting, preceptor, some of the challenges you might face, and then specifically talk about airways and helping someone through airways. And I have a couple of questions to go through. So if you're ready, we'll just get started. This is going to be kind of like an open type of conversation. Um, so we'll see how it goes. All
All
right.
right. Let's do it.
First question. What are some of the challenges that a preceptor may face?
So during intubation, right?
Let's do in general right now, in your opinion, like as a preceptor, we'll just talk about what some of the challenges that they would face in general with a new person that they're trying to walk through the day with.
Yeah, I think one of the hardest parts about being, the preceptor-preceptee relationship is in the very beginning when you don't know what that preceptee's level is, their level of
Yeah,
knowledge and confidence and so forth.
yeah,
Some personalities just match together pretty well, and others require a different approach.
hmm
So that first kind of feeling each other out period where, where's your areas of strength and weakness are definitely going to be the most important in
right.
developing that relationship.
hmm Yeah, I would agree. That would if I'm precepting, that's going to be my first questions. Is going to be where are you at in the process? What is your comfort level? And how can I help you meet your goals for the day specifically? So yeah,
Yeah.
that's good.
When I'm with a resident in the hospital and I've never worked with them before, usually the first thing I'll ask is, what can we work on today? What
hmm
do you want to focus on? What do you feel good about? And where
Yeah.
do you feel like we really need to focus our efforts today?
Yeah. What if you have a resident that's like super shy or doesn't want to like it says like I don't know. Do you not
Yeah.
just like do you like open their book essentially or do you have a good idea of what they actually need beforehand and that's more of like a ice breaking kind of leading question, let's get some stuff done type thing.
Well, usually I'll ask some probing questions like,
hmm
well, tell me about a recent patient you took care of,
Okay,
or
okay.
where your interest in medicine. Is there a particular area you feel like you've seen a lot of recently, or
Mhm.
is there something that you really feel like you haven't seen at all? And then we can kind of go based off of that.
Okay, gotcha.
For example, if they're like, I've never intubated somebody before, we can talk. All right, well, let's talk about that, and then hopefully
Mm,
we'll be able to perform it later in the day. Of course, depends on the
okay.
day, but certainly kind of gives me a little roadmap and tries to get down into what they're thinking and what their background is.
Gotcha. Gotcha. Yeah, that's good. Cool. Question number two. How can they tell who is proficient and who may need more help? And I guess that kind of answers that question. You kind of just have to dig into it a little bit and ask some questions as far as what is your past experience? What have you done recently? What haven't you done recently? And then kind of just based off that information, judge where the person would be, where the ALS candidate is in the process and their skill level. Now,
Yeah, absolutely.
there's certain things that you look for, like ticks or anything that they, not ticks per se, but like easy to assess confidence levels is like how they talk to you important, that kind of stuff, or is that really you'll just get it as it goes on throughout the day?
Well, no, I think actually listening to how someone talks gives you a lot of information,
hmm
especially a preceptee. Sometimes people will want to impress you and
Mm,
they'll try to be overconfident and talk maybe above their actual knowledge. And sometimes you
do
can
that.
get like, you can understand people like, people don't talk like that. Like, do you really know what you're talking about? And then that
Yeah.
can give me something to be like, all right, I really need to keep an eye on this. Or if someone talks confidently and uses the language and the verbiage that we would normally use,
Right.
someone that's confident, that helps me understand. Okay, I think they actually do know what they what they're doing here.
Okay.
It's a lot of like reading between the lines and reading their interactions with you.
Okay. Okay. Um, third question. When do you intervene? Oh, this is a good one. When do you intervene and then how do you do that?
So with intubation specifically, right?
Yeah, let's talk about intubation specifically, but the same principle will be applied to any high risk, low frequency thing that we do.
Sure. So with intubation, or really even like if they're just doing a patient's physical exam or history, I do want them to struggle a little bit. What it comes down to, though, and the golden rule here is that the patient should not suffer any harm because they are being cared for partially by a trainee. There is some degree of risk when you're being cared for by a trainee, but as the preceptor, you need to make sure the patient's not being harmed by the trainee, either from not doing something or doing something incorrectly or poorly. So, for example, let's think about intubation.
Mhm.
Intubation, we all know, is a fairly rare procedure, all things considered, and a very high risk. But it's something that people need to get confidence in.
Mhm.
So I will first assess whether or not the paramedic has an idea about intubation. Do they know how to set everything up when there's a low risk, low stress? If they're not even setting things up correctly, if they can't set up the UE scope, they can't set up suction, then I'm like, well, maybe the next one will be the one that you can do, and I'll show you how I intubate. However, if they're able to confidently tell me how they're going to go through the procedure and they're able to get all the equipment ready, then I think they are, it warrants them having an attempt at intubation.
Mm.
I will give them a little bit of a longer leash because I know that as the preceptor and as the senior clinician on scene, I can generally get them out of any trouble that they're sticking themselves into.
Mhm.
However, for example, intubation, I'm not going to, let them go any longer than I would, let myself go. So, for example, if that intubation is going for, more than a minute, we're gonna, cut it and either take it out or let someone else do the intubation. Or if that patient is, let's say, an RSI and they're starting to become hypoxic, or there's a lot of secretions, or I feel like the paramedic is not managing the airway in a way that I would consider appropriate, then I would take over and say, why don't we stop this intubation attempt?
Mm.
I'll do it. I'll show you how I do it. I'll show you why I think you've gone astray. And then next time we can do that intubation in a way that I think is corrected, a little bit different to make it more successful.
Mhm. Mhm. And practically, you're having that conversation as you have stopped the procedure, like hard stop, and then they're bagging the patient, and then you're having that conversation while he's being reoxygenated or the patient's being reoxygenated, not necessarily like while they're doing the attempt. So I know that sometimes we have some candidates who potentially might disagree and say, no, I can get it,
Mhm.
or I'm going to keep trying. How do you kind of address that situation? Is there like, do you have a phrase that you use or a predetermined thing that you do that you've communicated beforehand, or do you just kind of like step up? It's like, no, we're done now.
I think it's important to set guardrails before the intubation.
Okay. Yeah.
Okay, you as the preceptee are going to do this first intubation attempt. You have 60 seconds. I'll be here with you. I'm going to help you navigate it. But if we get to a certain like hard stop, then the intubation attempt is going to be over. And that
Mhm.
way, everybody knows going into this, because there is this this desire to be like, I almost got it. I almost got it, a little bit longer, a little bit longer.
Yeah.
That's how you have issues with hypoxic arrest, anoxic brain injury, and this occurs in operating rooms. This
Mm.
occurs not just in the back of an ambulance. This phenomenon occurs to anybody doing a high risk procedure where they get that tunnel vision. And it's really important, like I said before, for the preceptor to make sure the patient is not being harmed because
Mm.
they're being worked on by a novice trainee.
Yeah. Yeah. That's actually super helpful. Just even for me personally, just how to basically pregame the whole show just to make sure that everyone's on the same page before you get into a difficult situation. Yeah,
Mhm.
that's a good point. Let's see. I think we actually talked about some of this too on question 4. What are some of your personal things you pay special attention to during an intubation? I kind of touched on that. Would be make sure there's no harm to the patient. Make sure that if you are watching like your sats and your vitals, just to make sure that the patient's okay still, and then not going beyond what what you would personally do during an intubation attempt, like the 60 seconds or something like that. And then potentially looking for like if there's any trauma being done to the like the airway and stuff like that. That's what you're paying attention to, I guess.
So the other things
Yeah.
I would pay attention to would be how the paramedic is setting up their equipment beforehand.
Mm,
Because if they are fumbling around with the equipment and
mm,
they look nervous, they're shaky, they're sweating and they're diaphoretic, I know that like I'm going to have to like bring their level down a little bit and calm them down, because they are clearly lacking in some confidence. if they are confidently putting together all the equipment before the intubation, getting all the suction, UE scope, everything set up, I can feel like, all right, I'm going to stay in the background. I'm going to let you keep going until I feel like you're going to run into an issue.
Mm-hmm.
Other things that I really pay special attention to is how they put the UE scope into the mouth. A lot of paramedics that are new will just dump the blade right into the mouth, right into the vomit or the blood or whatever. So I try to
Yeah.
slow them down a little bit. All right, let's slowly, methodically put the UE scope in so we don't cover the camera. And then the other thing I approach is how they insert the endotracheal tube into the mouth, and the way that they are directing the ET tube down to the trachea. A lot of people will like to grasp the bottom of the ET tube, like towards the balloon, but I find that you get a lot more manipulation, a lot more fine manipulation by grabbing the top of the stylet to manipulate it. And so that's some of the things that I look at. And then, of course, making sure they're not hitting the teeth or the lips or anything like that with their UE scope. Not as big a deal with the UE scope, but with direct laryngoscopy, of course, is.
Yeah.
Everyone's come close to knocking a tooth out before.
Yeah. I have not done it yet. I have not done it, thankfully.
Neither have I. I mean, I've done it on some mannequins.
I know, especially with the supraglottic airways now. That's I don't have to try super hard. You know, if it's a difficult airway, that's something I can just fall back to, which is nice. And the technology is nice now.
The big thing would be putting the blade in the mouth. And then one other thing I wanted to mention was when the tube is in the mouth and you can see the glottic opening, a novice paramedic will often stab, do like some stabbing maneuvers, stabbing attempts with the ET tube right into the glottic opening, and then usually hit the arytenoids and the tonsils. And so I try to get them calm and make them thoughtful with how they're moving the ET tube. So we're not causing any trauma like you were mentioning before.
Oh, that's excellent. This is my last question. This is going really fast, and I really appreciate it.
Of course.
Love the time that we're able to commit to this. Any other tips and tricks for helping airway management in general? I think we talked about it a lot, but if there's anything else that you can think of specific with a preceptor helping to guide a preceptee or ALS candidate through that process, anything else that you can think of, overarching things?
Yeah. So airway management is much more than just intubation. A lot of like what Dr. Margolis teaches with the RSI monthly sessions is that we need to pre-oxygenate. We need to focus a lot on just the BLS maneuvers, the bag mask ventilation, and really optimize our patient before we intubate. Then we often intubate and we hand the bag to somebody that's like the least trained generally. This is like, the EMT student, here, go bag the patient.
Hey, new guy. Yeah.
It doesn't stop there. And there's so much more nuance that goes into intubation. How easily are we bagging? How much are we bagging? How frequently are we bagging? And that is just so critically important. Intubation is exciting, it's fun, but it is just purely a procedure when, as a paramedic, I mean, I could teach anyone to do intubation. What is special about being a paramedic, your training gives you that whole focused approach. The idea that this is not just an intubation, this is airway ventilation, this is oxygenation, this is the whole patient. And how does this play into what's going on with the patient? For example, Chief Shannon recently had a case where they were ventilating, they had a hard time ventilating, which was due to ultimately a tension pneumothorax from chest compressions. And that really, I have to give that whoever was bagging that patient a lot of credit, because they identified that it was harder and harder to bag. And they went through their dope mnemonic to figure out what was going on. And so if you're just thinking as, I intubate and now I hand it to someone to bag, and well, they're going to bag whoever they're going to bag, fast, slow, whatever, then that's not really the right approach. You have to think about it as way more nuanced than that.
Yeah, and as a preceptor, you're guiding another person through that thought process. Because they if they're new, they might not have put all those pieces together. Like they might be super zeroed in on the intubation, and then okay, I'm not worried about anything else. When actuality, in order to be cleared as a clinician, you need to be thinking about all that other stuff to help delegate those ideas. Like if it becomes difficult to bag, let me know, or to equip your BLS provider with the ability to tell when something goes wrong. And the skills necessary to be a good asset to you as the ALS clinician. Yeah, that's a good point.
The paramedics now. there's usually a lot of resources in calls at Howard County, but the paramedic has a real challenge, which is they have to be both the person performing these advanced procedures, but also the person that's running the resuscitation that needs the bird's eye view of what's going on. And it's a challenge to focus on the intubation while maintaining that situational awareness of what's going on everywhere else. And so it's just something I think that comes with time. But one of the things that a senior preceptor can show the preceptee is how to maintain that mindfulness of how to keep everything in the back of your head about what's going on and not get stuck on one particular thing.
Yeah, yeah, and that causes us a lot of QA issues is when we get tunnel vision and we get stuck on one thing and not able to see the big picture. But that does take time. So it's not we're not that's something that's a good point to make is it'd be tough for a new person, even someone who's been cleared for a year, to be able to take a very chaotic scene and keep all that mindfulness in their
Mm.
head. Um, so yeah, we're not looking for like I'm personally as a preceptor not looking for someone to be perfect at this in order to be cleared. I'm looking at someone who's capable of handling uh, to a certain level, and then be able to reach out for help once they recognize that they're getting somewhere where they're a little uncomfortable.
Absolutely.
Um, yeah, I mean, we're not expecting people to be perfect all the time, but we're expecting people to have the ability to reach out for help and to recognize when they might not be doing something correctly or might need to be have a little extra help with something. So, yeah, that's a really good point. But that's a growing process that we do pretty much all our careers is become more and more mindful with more and more difficult scenes. So.
Yep, absolutely.
Um, that's all the questions I had for this. I didn't want to make it too long just because everyone's going to be required to watch this. So,
Well, hopefully you can put it on 2x.
sorry. Well, I'll try to cut it down a little bit. Well, no, I might just, yeah, I'll see what I can do. I don't, we'll see. We'll see.
Yeah,
Thank you so much for your time. I really
sure.
appreciate you. Uh, yeah, thank you.
Yeah, of course.
Any other parting words?
No, I mean, I think being a preceptor, thank everybody that agrees to be a preceptor. It's a really difficult job, but
Yeah.
it's so incredibly important for the
Mhm.
department and for the next generation of paramedics to have high quality preceptors.
Yeah, couldn't agree with you more. Well, thank you for your time. I really appreciate you, Doctor. Have a good rest of your day. Stay safe out there, and I'll see you on the next one.
Thanks. You too.
Your brother.